and synovial fluid in the bone, again to reduce friction and indeed to maintain regeneration of the bone. Synovial fluid contains and to lubricate the bone. So this is the synovial membrane. Shall we say, just say synovium, and this is synovial fluid, which contains hyaluronic acid. It contains lubricin to lubricate, and it also contains a filter flow from the plasma, filtered plasma, or plasma filter, really, shall we say. Obviously, the hyaluronic acid is part of the proteoglycans, including the being secreted by, although it's secreted by fibroblasts. Fibroblasts. That is secreted by chondrocytes as well. Lubricin is secreted by the extracellular matrix as well, and this is just plasma filter. And this synovial fluid plays a huge role in the pathology of rheumatoid arthritis, which is completely different from osteoarthritis, where the pathology is based on the destruction of the cartilage, propagating or transmitting into bone destruction and then extending outwards to then affect the synovial joint lining, the ligaments and the tendons, and indeed the muscles. So obviously we will have our ligament there, the capsule as well, to hold and stabilize that joint, and indeed the tendons and the inserted muscles as well. So while osteoarthritis, as I previously discussed, will start at the cartilage and move towards the peripheral, synovial inflammation from arthritis actually starts at the synovium itself, the synovial lining, and move centrally into the cartilage and the bone. So we'll have our inflammation starting at the synovium there, moving centrally into the bone. And the inflammation that occurs really is based on T cell inflammation, obviously propagated by macrophage activation due to cytokines, and indeed the rheumatoid factor, and indeed the anti-CCP. Both these two will be secreted by plasma cells. So in chronic inflammation, we will have, I'm trying to see if I can use a different color altogether. As that inflammation continues, and we're talking about weeks to months of chronic inflammation, a pannus, which is granulation, like granules of inflammation, will form at the synovial lining there. So we'll call that a pannus. And as it continues to grow, it obviously obstructs cartilage regeneration, and it grows into the synovial fluid as well, and disturbs that viscosity of the fluid. And in doing so, it destroys basically the fluid integrity, and it also causes cartilage degradation. And when cartilage degrades, it naturally wants to undertake repair, but obviously, you know, the chondrocytes are affected, so that repair mechanism will not be a perfect remodeling. And because this is obviously happening faster than the normal regeneration, there will be degradation and there will be destruction of cartilage anyway. And then we also have importantly, activated rank and rank ligand in that synovium. And what rank and rank ligand are they are members of the TNF family, and they activate osteoclasts, because really their main function is bone remodeling. And osteoclast activation, obviously we know that osteoclasts destroy bone. So in that chronic inflammatory phase, we will have the hallmarks of chronic inflammation in RA will be, number one, that pannus in the synovium, progressing centrally into the bone and cartilage, to destroy bone cartilage, shall we say, because obviously cartilage destruction occurs first and then bone later. And then we'll also have constant inflammatory cytokines and constant inflammation, really. And then we'll also have the rank and rank, the TNF family. Shall we just say osteoclasts? And really, once bone destruction occurs, the pathology is more pronounced, and again, with a pronounced pathology, with pronounced inflammation, we will then have the atrophying of ligaments and capsule. Obviously, while the synovium itself hyper atrophies and becomes larger, extending into the cartilage and the bone. So once we have the ligament and capsule atrophying, muscle atrophy occurs, leading to subluxation, really, of that joint. So at the end of phase 3, which is the disease stage, we'll have all the clinical features of rheumatoid arthritis. For example, we'll have the pannus and the nodules that are formed. We'll have the destruction of cartilage, which, although is a secondary pathology leading to bone destruction, means that we'll end up with secondary OA to contend with as well. We'll also have that constant inflammation, which leads to edema, neovascularization of all the vessels of the synovium, because obviously you have to remember that there are vessels in there that feed the joint and the structures of the joint. So we'll have neovascularization as well. We'll have a lot of edema, leading to a lot of invaginization of T cells. So we'll have edema due to inflammation, and a lot of adhesion molecules being expressed for T cells and other inflammatory circuits such as VCAM1. We'll also have VEGF and other growth factors leading to neovascularization. And obviously, as these new vessels grow, because they're not growing in a healthy environment, all that really does is propagate the inflammation and propagate the survival of inflammatory cells. And if we were to look at the nodules that are formed, even the nodules that are formed in rheumatology, they would usually look like the TB nodule, which I described when I was doing respiratory medicine, where there will be a central necrosis that is walled off by macrophages to keep that inflammatory process going on forever and ever, given that it is a chronic inflammation after all that we are talking about. So the hallmarks of rheumatoid arthritis will of course include edema, as we will see via a swollen joint that looks red and tender, edema leading to inflammation as well, again causing a lot of pain and that stiffness due to inflammation. We will also have the formation of nodules. Again, we will see it in the joint as a painless formation. However, these nodules form everywhere, and indeed they are based on the picture that we see there. We will eventually have the destabilization of that joint, causing deformities that include fixed flexion deformities. So then now, once we are in phase 3, really, this is when patients usually know that there is something wrong. This is when patients usually know that there is something wrong and they present. So the clinical presentation will be the description of the disease, really, in terms of people will present with painful, swollen, stiff joint where there is pronounced early morning stiffness, they will also pronounce with the joint will be tender as well, and it will look, edematous. Obviously, the patient will not say that, so I will not write it down. Patients will also present with tiredness, where there is reduced use of the joints. Patients also present with tiredness and non-specific symptoms such as weight loss. They will also talk about joint instability, being unable to use that joint because it keeps giving. So they will talk about joint instability. And really, once these are the actual presenting complaints that the patient will say, but medically, these presenting complaints will obviously include, I'll leave number 1 as it is because I think that really is, but that that stiffness and pain. So the joint stiffness and pain will be lasting more than 1 hour in the morning for that joint to become functional and for the patient to be able to use it, due to the fact that obviously inflammation will ease off as one gently uses the joint in the morning. So there will be subluxation of that joint, and there will be anemia of chronic disease. And again, it will usually be small joints, hands especially. But obviously, RA can affect all synovial joints, including the MCPs, the PIPs, the DIPs. It can also affect the wrist joints, leading obviously to ulnar deviation. It can also affect the elbows. We see a lot of rheumatoid nodules in the elbow. It can affect the shoulder as well, leading to impingement and rotator cuff issues, and particularly, impingement being that painful arc from 60 degrees from being unable to raise the arm between 60 degrees to 120 degrees without any pain, when there is against resistance or against active abduction of that arm. So there will be that painful arc. So when a patient presents, the investigations that have to be done include the clinical assessment, and the clinical assessment is based on in order to diagnose this disease. It's based on, number one, a clinical assessment based on the presenting complaints, and it will be defined by the American Rheumatology Association scoring system, where one has to, in order to have a definitive diagnosis, they have to score 4 out of 7 aspects that are required on that score. I'll discuss it in a minute. The other investigations that are actually used are, a full blood count that will show normocytic, normochronic anemia, which is obviously the anemia of chronic disease. Normochronic is obviously anemia of chronic disease. The inflammatory markers will be the inflammatory screening, really will show a raised ESR and raised CRP. Again, remembering these are acute phase proteins that propagate that TNF, IL-1 and IL-6 inflammatory process, leading to constant activation of macrophages, which really are the basis of the T-cell inflammation that is seen in RA. The specific tests will include testing for the rheumatoid factor, which, although I'm saying specific, it's not really specific, however, it's quite sensitive. Shall we say specific disease test, really, in that about 70% of people will have it, will be positive. ANA can be done, but ANA is even less sensitive. Only about 30% cases will be ANA positive. However, anti-CCP is highly specific for rheumatoid arthritis, and about 90% of cases will be positive. And obviously, when I talk about rheumatoid factor being non-specific and ANA, it means that other seropositive diseases such as sarcoidosis, which I discussed in respiratory medicine, such as SLE, such as Wagner granulomatosis, will have a positive rheumatoid factor. So although it is tested because it is sensitive for the disease, it is actually non-specific, and anti-CPP is, however, specific for rheumatoid arthritis. And then what one also needs to do is baseline radiology, which really will not show anything due to the fact that early rheumatoid arthritis usually affects tissue, so there is tissue inflammation, but there won't be any bone pathology. So the baseline radiology might not show anything. However, it is good to have that baseline radiology because it will be used in later stages to assess prognosis. So it's quite important to do it, really. And also, one would then need to absolutely undertake a disease activity score 28, which is obviously based on the 28 joints that are commonly affected, which are the hands, the wrist, the elbow, the shoulder. So once all of that is done, and if it's positive, then a treatment plan has to be undertaken. But before I go into the treatment plan, I'm just going to discuss the scoring system based on the American Rheumatic Association and the disease activity score. So the 7 features that are looked for in the American scoring system that we use to have a definitive clinical diagnosis of RA include, number 1, joint pain and stiffness, like shall we say morning joint pain and stiffness that lasts more than 1 hour every morning. The hands must be affected. It has to be symmetrical, because obviously we know that RA is a symmetric disease. It has to be RF positive, albeit that RF is not really specific. It is sensitive though. There have to be some radiological features, and I think these two are separated. Oh. I'm trying to think. And all these and they have to be nodules as well. Rheumatoid, cutaneous nodules, which obviously I discussed in the sense that histologically they look like the TB nodules found in the lung, or really the other nodules that are seen in diseases like sarcoidosis, which affect the lungs as well. So one needs to have any 4 out of the 7, and all of these have to be present for at least 6 months. No, for at least 6 weeks. I'm sorry, 6 weeks, in order for that to be absolutely positive. So if someone scores, the golden number 4 out of 7, and then all the bloods and the investigations which I've just discussed are undertaken, and they are returned as being positive, a disease activity score 28 as well must be completed. And the disease activity score is important to complete because it also measures prognosis, number 1, and also it is used to determine if biologics are going to be administered. So the DSA 28, again 28 based on the number of joints that are involved, will include the number of affected joints, the inflammatory markers, which are just ESR and CRP, C-reactive protein, and then it will also do the general assessment score, general health assessment score, and then it will grade the disease activity. And the grading system that is used is that anyone with a DSA 28 of more than 5.1 is classed as having active disease, and then anyone with less than 3.2 is classed as having this is classed as being severe active disease, really. Again, this is still active disease, but it's less severe, obviously. Less active disease, but it's still active. And then